Hi everyone, I hope I am audible to you and visible also. My slide, I mean. Let's start with today's session. Today's session is going to be one of the most requested sessions, that is how to identify at which level of the spinal cord do we have a lesion. Okay, now we are going to go to clinically oriented basics, and on those basics we are going to try to build our concepts of medicine. Okay, so the first and foremost important concept I want you to understand is how is the orientation of the spinal cord in the spine, how are the spinal nerves exiting or traversing. Right, now the first and foremost important thing I want you to notice over here, that in cervical spine, okay, in cervical spine you will note that if this is a vertebra, say C1 vertebra, the spinal nerve of this root is leaving above the level of vertebra, right? Similarly, if I draw C2, then the spinal nerve of that level is leaving above C2. So if you look here very carefully, then this nerve is C1, this nerve is C2. This is what is the orientation in almost entire cervical column. But the change happens when it goes to C7 vertebra. Okay, when it goes to C7 vertebra, we know that even though there are 7 vertebrae, there are 8 spinal nerves, 8 cervical spinal nerves. So here in C7, what happens is you can see C7 exiting above and C8 exiting below the 7th cervical vertebra. And because of this, henceforth after C7, in the entire column, any vertebra, if you take, whose number is say suppose X, then the spinal nerve of that vertebral level, that is spinal nerve X, will be leaving below. Okay, so what 3 points I want you to understand is the cervical segment, the cervical spine up to C7, all the nerves exit above the level of that vertebra. So if I ask you an example of C4, which nerve will be exiting above C4? The nerve which will be exiting above C4 will be C4 nerve, C4 spinal nerve. If I ask you what is the nerve exiting between C5 C6 spinal segment, C5 C6 spinal segment, C5 or C6, right? C5 or C6 के बीच में which nerve will be going between C5 and C6? It will be C6 nerve, right? It will be C6 nerve. Understood? This is what is the concept for cervical. Then the concept comes is at C7, since there are 7 cervical vertebrae but 8 spinal nerves in the cervical region, at C7 the C7 nerve exists above and C8 exits below, and henceforth after that up to the sacral coccygeal vertebrae, all the nerves will be leaving below that specific level of vertebra. Clear? This is the first concept I want you to be cleared of. Okay, so if I ask you one more example, okay, L4 L5, if I ask you, okay, I am taking that concept also about the intervertebral disc because it is a slightly different entity to understand. If I ask you a simple question, between L4 L5, which will be the exiting nerve and which will be the traversing nerve? Now what do you mean by traversing? Traversing means the nerve which is passing straight through the spinal cord. Suppose this is the spinal segment, then exiting nerve is the nerve which goes out through the vertebral column, goes to supply its specific region, and this is called an exiting nerve. Whereas a nerve which is passing through and through to the lower segment will be called as a traversing nerve. Okay, now if you have a nerve, your segment L4 L5, now tell me at the level of L4 L5 which will be the traversing nerve, which would be the exiting now. Now I told you after C7 in any column till coccygeal definitely will involve lumbar. So for that, between any two vertebrae, which nerve will be there, like L4 or L5 के बीच में, which nerve is going to be there? Definitely it is going to be which nerve? It is going to be L4. So the exiting nerve will be L4 here, whereas the traversing nerve will be L5 and so on. Right? Any nerve involving L5 and others below that level will be the traversing nerves. So I want you to understand that exiting nerve will be L4. So if there is a direct impact, that means external compression of L4 L5 segment, what will happen, and what will happen if there is intervertebral disc injury? Okay, if there is a direct impact, definitely think most laterally. What is the nerve? Is the exiting nerve present more laterally or traversing nerve? It is the exiting nerve which is most lateral, and that's why with direct impact L4 spinal nerve will be involved, right? L4 spinal nerve will be involved. But what would happen in an intervertebral disc prolapse? Let's look at this image itself that we saw about the spine from behind. Okay, from behind. Imagine this is L4. Imagine this is L5. Now tell me, this is L4 L5 intervertebral disc. Imagine there is intervertebral disc here. Okay. Now I have a nerve which is coming from here. Which nerve will be the exiting nerve between L4 L5? That will be L4, right? Which would be the traversing nerve? It will be L5, right? So from this you get that if I am having an intervertebral disc prolapse, what would happen? Which nerve would be injured? So always remember, intervertebral disc prolapse is most commonly 90% of the times it is central. Basically it is paracentral, right? So the intervertebral disc will compress this specific segment which is getting prolapsed, right? So L4 L5 intervertebral disc prolapse will cause which spinal nerve injury? Will cause compression of L5. It will cause compression of L5. That's simple. Yes. Okay. So that's the concept. So the concept basically to be learned here is that if there is a intervertebral disc prolapse which is most commonly paracentral, you will get the compression of segment level below. What does this mean? Whatever segment you are taking, a nerve below that segment will be injured, whereas if it is a lateral compression, the same level will be involved. That is what I have taught from this basic concept. Okay, chalo. फिर now we have to now see the next basic concept to be understood. See, any spinal nerve which is coming out will have its own dermatome, that is a specific region which is going to supply, right? It is also going to have its own myotome, that is a specific group of muscles which will contract, and multiple such spinal nerves will form combinations to produce reflexes. So based on these three concepts, we identify at what level is the injury, based on myotome, based on dermatome, and based on reflexes. So let's understand very basic thing to understand. See, the main major thing is which is going to help you to understand is the upper limb and lower limb, because these are the most commonly involved structures when it comes to spinal compression or injuries. Okay, now let's look at this diagram. It looks pretty complicated, but let me make a simpler diagram for you to understand, and it will be pretty easy. Let's look at this. Let's have a look at an upper limb, suppose. Okay, this is the neck, this is the shoulder, this is the arm, This is the trunk, this is the arm, then you have forearm, and after forearm you are having the lateral finger, that is the thumb, index finger, middle finger, ring finger, and the little finger. I know the diagram is not pretty good, but yes, this can help you to understand many things. Okay, now the thing is very simple. Start from the center, go laterally, come down, and again come medially. What does this mean? This is the route how the nerve, your dermatomes are actually traveling. Okay, this is how your dermatome are basically traveling. So what you need to understand here is, if I want to make a dermatome here, yes, at the level of your neck is the dermatome C3, right? Then at the level of the shoulder and the deltoid region is your dermatome C4. Okay, so everything has gone very pretty clear. Now when we come to the upper limb, divide it into half up to the hand. Okay, you have arm, forearm, and the hand. Now in the forearm, in the arm, the first half I told you, we are going from central to lateral. This comes out to be C5, this comes out to be the entire part, that is C6. Okay, that is the lateral aspect of the forearm and the thumb, it becomes C6. Then the middle three fingers will become C7. The lateral half of the forearm will become C8, and this medial half of the forearm, hand, and the medial half of the arm will become T1. Simple thing to remember. So how is the progression? Medially, going downwards laterally, and again coming up medially. This is how you need to remember the dermatome of the upper limb. Yes, shoulder pe C4, deltoid region pe C4, lateral half of the arm is C5, lateral half of the forearm and the thumb region, that is the thenar eminence and the thumb, will become C6. The middle three fingers and the middle and the palm related to that will become C7. The medial finger, that is the ring or your little finger, the medial aspect of palm, medial aspect of forearm will become C8, and the medial aspect of arm and the axillary region will become T1. It's that simple to remember. Okay, next let's look at the lower limb. Lower limb is more easy to remember. Okay, very easy to remember. Okay, imagine this is the groin region. This entire groin region is basically supplied by L1. Okay, then comes the anterior aspect of thigh. Anterior aspect of thigh is supplied by L2. Okay, then comes the anterior aspect of knee. Okay, anterior as well as posterior, it remains the same. Okay, so basically knee, it comes out to be L3, right? Anterior aspect of knee, it comes out to be L3, right? Then let's go a bit downwards. Come up medially here now. Okay, we always know upper limb के उल्टा lower limb होता है हमेशा. So when it comes to medial aspect, the medial aspect of the thigh or your leg and the ankle. So the medial aspect of the leg as well as the ankle, it becomes L4. Then the lateral aspect of the leg and the dorsum. So lateral leg, dorsum, great toe, it becomes L5. So if this is the great toe, this much part will become L5, and this much part remaining up, that is the other toes, little toe, will become S1, right? I know it's going a bit up, let me revise you, it's very simple to understand. Groin region is L1, anterior thigh is L2, anterior aspect of knee is L3, medial aspect of the leg as well as the medial aspect of the ankle will become L4. The lateral aspect of the leg and the ankle, dorsum and the great toe becomes L4, and the remaining part of the toes will become S1. It's that simple. These are the only dermatome that we need to basically understand. Now what is the clinical application of this? The clinical application of this basically is, if you are having, say suppose you are having injury involving the spinal segment C5 C6. Okay, if you are having the injury involving C5 C6, we'll come to motor and reflex. Let's talk about dermatomal supply. If I give you an example, there is a involving spinal segment C5 C6. Tell me which nerve will be coming out or will be an exiting nerve for C5 C6. Which nerve will be the exiting nerve for C5 C6? It will be C6, right? Because I told you in cervical region, the nerve above that specific vertebral level will be there, right? So C6 will be the nerve. Now tell me, you know dermatomal supply, which area of your upper limb is supplied by C6? Lateral aspect of forearm, thenar eminence, thumb, palmar aspect of of your hand, and the area related to that lateral aspect, right? So that will become C6. So automatically what will happen? How will the patient present with? The patient will present with loss of sensation in this area. That is how your dermatomes are going to help you, right? We are going to solve an MCQ after this. Everything will become simple. Okay, I purposefully decided to take these basics because there were doubts that, sir, how to remember this. It's very easy. Okay, these are the only things you need to remember. Now myotomes, how to remember these? Very simple. We are going to take myotomes from C5 to S1. Okay, how are these myotomes basically going? Very simple. Extend your both the hands. Okay, extend your both the hands at the wrist, at the elbow. Very simple. Now you are going to take your entire hand close to your body. Now if you're taking your hand very close to your body, that means first thing you will need to do is a elbow flexion. Imagine this is your hand, this is the wrist, this is the elbow, this is the shoulder. Okay, if you are taking your hand close to your body, the first thing you need to do is elbow flexion, right? So the first thing that you are going to do is elbow flexion. So the elbow flexion के लिए your myotome becomes C5, right? After that, once you do a elbow flexion, what you need to do to take your entire upper limb close, you need to do wrist extension, right? If the wrist is extended, then only the entire upper limb will come close to your body. So wrist extension comes at C6. Okay, so that is now what you have done. Now you need to take your entire limb again away from the body. You have taken your upper limb close to your body by elbow flexion and wrist extension, that is C5 and C6. Now you are going to do the opposite thing, take everything away. So wrist flexion and elbow extension will be C7. Okay, so wrist flexion and elbow extension will be C7. Understood the trick to remember? Okay. After this, the thing remains is your hands, your fingers. So now you have taken your entire upper limb away from the body. So you need to flex and abduct your fingers. C8 is the myotome for finger flexors. Okay, this is a myotome for finger flexors, whereas T1 is a myotome for finger abductors. Understood? Simple thing to remember. Just do this practically. Try to extend your hands at your wrist and elbow. Keep them at rest. Now bring your elbow close to your body, that is elbow flexion, C5. Wrist extension, again your hand will be more close, that will be C6. Do the opposite of this, wrist flexion and elbow extension, C7. Finger flexion, C8. Finger abduction, T1. It's that simple, right? Next, let's go to L1, L2. The same thing goes with lower limb. Now if you want to take your lower limb very close to your body, what you need to do first, hip you need to flex. So hip flexion is the myotome, L1, L2. Then you need to extend the knee, right? So knee extension is L3. Ankle needs to be dorsiflexed, ankle dorsiflexion. I'll draw a simple diagram. Yes, this is your hip, this is your knee, this is your ankle, and these are your fingers, right? To bring your body close, you need to flex the hip first, that is L1, L2. Then you need to extend the knee further, that is L3. You need to dorsiflex the ankle, that is L4, right? Then you need to dorsiflex your great toe, that is extensor hallucis longus, that is great toe extension, that will become L5. And finally you need to do ankle plantar flexion, that is the last thing that we are going to do, ankle plantar flexion, that is S1. Very simple. This everything talks about the myotomes and it's that easy, right? Take your upper limb closer, take it again away. Take your lower limb closer and take the ankle plantar flexion at the end, right? This is how you need to remember. Now why I am taking this, because remembering these three lists, there is one more list, that is the reflexes. Once you know these three lists, solving and understanding any level becomes very easy. I'll come to a question. Now let's come to the reflexes. Now many times we get confused that what is the root value of this reflex, what is the root value of that reflex. So this is a very simple mnemonic to remember the reflexes root value. Okay, now the mnemonic is very simple. 1, 2, buckle my shoe. When you are buckling the shoe, at which joint are you working on? You are working at ankle jerk, right? Ankle joint. So this talks about ankle reflex. The ankle reflex, it is S1, S2. Next is 3, 4, kick the door. When you are kicking the door off, what you are doing? You are doing a knee reflex. Your knee reflex is kicking the door away. The knee jerk is L3, L4. Then you have pick up the stick. If you have to pick up the stick with your hands, what are you doing? You are flexing your hands. You are flexing your elbow. What is the flexor of elbow you are looking for in the reflexes? Biceps brachii. So biceps jerk, C5, C6, and shut the gate. You have to shut the gate apart. You have to extend the elbow. That is triceps jerk, right? Triceps jerk, C7, C8. Simple thing to remember. Important reflexes, root values, done, right? If I say there is the same injury, C5, C6, C5, C6 nerves have been injured, lesion C5, C6 pair, which myotome will be involved? Elbow flexion, wrist extension. So if you are trying to do elbow flexion and wrist extension, that will be weak. Dermatome, C5, C6 ka dermatome, lateral aspect of arm, lateral aspect of forearm and thumb. No sensations, right? Reflexes, C5, C6 is injured, which reflex will be poor? Biceps jerk. Simple to understand. Okay, let's come to the next thing, is about the tracts. Now I'm not taking the tracts very great in details, but just the points to remember which will help you to analyze what is the level of lesion now. Please pay attention to this. This is very simple and easy to understand. There are three basic tracts we need to understand. One is corticospinal tract, which is your motor tract. Second is spinothalamic tract, which is your anterolateral, and the dorsal column or posterior column tract. Now motor tract, corticospinal tract, this is a very simple diagram to understand, originating from the cortex. Suppose this is the left side, this is the right side. Okay, from the left side, if the tract is coming from the cortex, it will extend downwards as a corticospinal tract till medulla. This corticospinal tract crosses to the opposite side. Yes, you can see this is crossing the opposite side at the level of medulla and extending down through the spinal cord. That means up till medulla everything goes on the same side, whereas in the spinal cord everything is crossing and going to the opposite side. And then it is ending on the anterior horn cell, and then the anterior horn cell will produce a motor nerve, which will supply a specific muscle. So the basic concept to understand here is up till here, that is up till the nerve, the corticospinal tract which ends at the anterior horn cell, this will be called as upper motor neuron, right? This will be called UMN, whereas your anterior horn cell and the motor nerve will be called as a lower motor neuron. So to understand what should be the important points about upper motor neuron and lower motor neuron palsy, upper motor neuron palsy will have spasticity and deep tendon reflexes will be brisk, will be exaggerated, right? Whereas lower motor neuron, same spinal segment level pe injury, what will happen? Your anterior horn cell or your motor neuron has been damaged, so the muscle will become flaccid, the deep tendon reflex will be absent. This is what we need to basically understand. So if I ask you a very simple thing, that imagine this is C5, okay, this is C5, I am having a lesion at C5. What will happen above? What will happen at this level? What will happen below? Now if you look at above, the lesion is at C5. The lesion is at C5. Everything above C5 will remain normal. Yes, because the spinal segments are absolutely normal. At C5, what will happen to the motor component? At the C5 to the motor component, what will happen? Anterior horn cell and the motor nerve will be injured. So you will get lower motor neuron palsy, flaccidity and deep tendon reflex will be absent. Whereas at the region or the levels below C5, it will act like upper motor neuron, because till then for the levels below C5, your corticospinal tract is still continuing to reach until that specific level, anterior horn cell. So this is what is you need to understand. Any level if you check, above that level it will be normal, at the level it will be lower motor neuron, below that level it will look like upper motor neuron, right? The next tract we need to understand is spinothalamic tract. What does spinothalamic tract carry? Two important things that you remember. It's okay, pain, temperature, done. Okay, how is this traveling? The sensory nerve of a specific segment is going ipsilaterally and traveling one segment above. Okay, it is traveling one segment above. Okay, and then one segment above it will be crossing. One segment above it will be crossing to the opposite side, extending above and ending into the ventroposterolateral nucleus of thalamus. This is how the thing is going to go. So now the same example if I take is C5 again. This is the level of lesion. What would happen to the sensations of pain and temperature above the level, at the level and below the level? Above the level, these will remain normal. At the level, what will happen? At that level, the same sensory nerve is present which has not yet crossed. So at the level, there will be ipsilateral spinothalamic tract involvement, right? So there will be same sided loss of pain and temperature. Simple. Whereas what will happen below that specific level, say suppose C6 पे देखना है तो लीजन इज एट C5 बट C6 की जो नर्व है वो क्रॉस करके आई है C5 पे. So what will happen at C6? There will be contralateral STT. There will be contralateral loss of spinothalamic tract path, that is contralateral opposite sided loss of pain and temperature. Simple. Okay, next. The next thing to understand and the last tract to remember is posterior column tract. Now what is about this posterior column tract? Now to understand posterior column tract, what is the function? The function, two functions I want you to remember. One is proprioception, that is the position, joint position sense, and second is vibration. The simple difference is that at any specific level the sensory nerve is coming. At that level it is ascending upwards till the medulla up to nucleus gracilis and nucleus cuneatus in the form of fasciculus gracilis and fasciculus cuneatus. We all know this from neuroanatomy. Now from the nucleus gracilis and cuneatus, at the level of medulla it is crossing opposite side and ascending upward as medial lemniscus. I hope you all remember this, medial lemniscus. And then it will be ending up again into the VPL, that is ventroposterolateral nucleus of thalamus, of the opposite side, right? So now if you understand that it is just ascending above, it is just ascending above, not crossing. So please remember that until your medulla, posterior column tract fibers are not crossing anywhere. So if I take the same thing, C5 पे lesion है, what will happen? The posterior column tract above will remain normal at the level of the lesion. What will happen? Ipsilateral, yes, same side के हैं तो ipsilateral posterior column tract involvement, that is same side पे there will be loss of vibration and proprioception. What will happen below? There will be same ipsilateral PCT, that is ipsilateral loss of proprioception and vibration. Why? Because your posterior column tract is not crossing till the level of medulla. Simple. Okay. So just to summarize this very quickly, I have a simple diagram just to check on what you have understood. Say suppose I have a segment A. I have a segment A. What would happen if there is a lesion at this segment? What should be the status above the level? What should be the status above the level? What should be the status at the level? What should be the status below the level? Let's integrate all the three tracks we have discussed till now. What would happen above the level? Think. Above the level, everything will remain normal, right? Everything will remain normal. At the level, think of all the three tracts. See, at the level, what is happening? First is motor tract, second is spinothalamic, third is dorsal column. Think. Motor tract, that is corticospinal. At the level, already the anterior horn cell and motor nerve is there. You are damaging that. So what will happen at the level? There will be ipsilateral lower motor neuron palsy. Okay? Hemisection के बारे में बात कर रहे हैं, right? What would happen to spinothalamic? What would happen to spinothalamic? Again, it will be ipsilateral, right? Same sided because it has not crossed at this level. So ipsilateral spinothalamic tract involvement, that is same sided loss of pain and temperature. What would happen to vibration and proprioception? Again, ipsilateral loss of PCT, right? What would happen below the level? For below the level, still the segment, your corticospinal tract is going. So below the level, it will become ipsilateral. It will become ipsilateral upper motor neuron type of palsy. Here it would be lower motor neuron. Yes. What would happen to spinothalamic tract? the level below sensory nerve will be crossing to this specific segment A, so this will become contralateral spinothalamic tract involvement. And below the level, what would happen, since it is never crossing, ipsilateral PCT. This is what is the overall look to the segments, the tracts. So if I am having, say, suppose I'll give you an example. There is a lesion at L4 segment. Tell me what is going to happen. What would happen at L4? What would happen above? What would happen below? What would happen at the level? So if you check at the level, what would happen above? Everything normal. At the level, if I say, suppose this is on the left side, okay, on the left side of the L4 there is left hemi section of L4. So at the L4, what will happen? Left sided lower motor neuron, left sided loss of spinothalamic tract, and left sided loss of posterior column tract. So the patient will have left side, the left upper limb, the left lower limb will be having flaccidity. The sensations will be of that specific area. The pain and temperature will be lost, and vibration proprioception will be lost. The area which is supplying L4. What was L4? Medial aspect of leg and ankle. Simple for the sensations. And what would happen below the level? Below the level, suppose if I ask you what would happen at L5. At L5, what would happen? There will be left-sided UMN. There will be right-sided spinothalamic tract involvement. That means right-sided L5 region sensations, that is a dorsum of the foot sensations of pain and temperature, will be gone. And again left-sided PCT, posterior column tract. This is what we need to basically understand, and integrating all of these concepts is what you basically need to understand to know all the things that we need to know now. Let's try to do 2 MCQs and everything will be sorted. I hope I have made everything easy. If you still have doubts after solving this MCQs, it would be cleared, and still after that if you have doubt, you can ask me on the Telegram group. Okay, now let's see this question. A middle-aged lady, you are having a middle-aged lady who is complaining of lower back pain. Always remember, adult lady, adult male or female, complaining of back pain, the most common cause of non-traumatic lower back pain is prolapse of intervertebral disc. Okay, traumatic is definitely spondylolysis and spondylolisthesis, but non-traumatic, since we cannot see any trauma history here, okay, it is most likely to be PIVD. But the question is asking something else. There is weak extension of right great toe. There is no any sensory impairment. MRI would show which level of PIVD. See, the grandmother is your mother-in-law is asking here, PIVD kidhar tha, right? Prolapse intervertebral disc kidhar tha, where is it? So simply we know that here the motor root is involved. You have to ask the PIVD. The simple thing, the only thing we need to basically understand here is weak extension of right great toe. This is the only keyword to remember. Now remember the myotomes I taught you. Great toe ka extension. What was the level? What was the myotome? Remember the myotome of lower limbs? What were the myotomes of lower limbs? The myotomes of lower limbs were hip flexion L1, L2, knee extension L3, ankle dorsiflexion L4, great toe extension L5, and ankle plantar flexion S1. So if I know that this is right great toe, this is right great toe, what I am talking about here, I am talking about L5, right? The myotome is L5. So I am thinking that possibly this is a lesion involving the spinal nerve L5. Now they are asking the levels. Now tell me, L3 L4 पे L5 नहीं आएगा, S1 S2 पे L5 नहीं आएगा. So the two of the options are L4 L5 and L5 S1. So now remember the first basic concept that I taught you about prolapsed intervertebral disc. If it is L5, which segment it is involved, L4 L5 or L5 S1? In PIVD I told you that if this is a limb L4, if this is L5, L4 is exiting and L5 is traversing. The intervertebral disc will compress the traversing root, right? It will compress the traversing root, right? Why? The reason is only lower back pain. Remember, if lower back pain is associated with limb abnormalities with sensory loss typically, then I would think of a lateral compression. But if it is lower back pain without sensory involvement, it's a paracentral disc prolapse. Okay, that means it has to be L4 L5 to compress L5. That's what we are seeing here. That's why the answer becomes option B. What would happen in L5 S1? Let's start thinking of this. If this is L5, this is S1, the nerve coming out is L5, going away is S1. So I would have got compression at S1. So think and tell me, if it would have been option C, that is L5 S1, what would have been the weak myotome? It would have been plantar flexion, right? So just remember those myotomes, remember those dermatomes, remember those reflexes. Everything is easy. Okay, one more question, and this is based on your tracks and how much understanding you have. Okay, you have a 32-year-old gentleman who has stab injury and neurological findings shown here, and the question asking is lesion kidhar tha? Where is the lesion? Where is the lesion? Lesion kidhar hai? Okay, you know that this is hemisection based on the options, but let's come to this question, this table given to you. Okay, let's think of very simple thing. See, always apply stepwise manner. Think of the tone first, then par. The question is also giving you that same thing. Okay, tone and par should be the first step, tendon reflexes should be the second step, sensation should be the third step. This is a stepwise manner you need to understand. Now look over here. The upper limb is flaccid on the right side. On the left side, both are normal. Okay, let's try drawing a simple diagram which would help you to understand many things in detail. Imagine this is the person, this is the trunk, these are the limbs of the person. Okay, let's try to understand this. Now in the upper limb, what we have? In the upper limb, we have that the right upper limb is flaccid, right lower limb is spastic. What does this simply mean? For the right upper limb, it is lower motor neuron. For right lower limb, it is upper motor neuron. When would this happen? Upper limb के लिए flaccid, lower limb के लिए spastic. When would this happen? If it is a cervical involvement, if this is cervical involvement, right? Cervical injury, right? Okay. Is the left side having anything? No, nothing. Fine. The par is also showing something similar things, not to be considered much of an importance. Now thinking about reflexes. See, biceps reflex is lost. Biceps reflex is lost on the right side. So biceps absent. Here lower limb reflexes are brisk. Again, I know that I am getting a right-sided cervical involvement. Why? Because again the same thing is reflecting. Upper limb के लिए lower motor neuron, lower limb के लिए upper motor neuron हो गया, right? Also the reflexes on opposite sides are normal. Fine. So I can say that this looks somewhat like a hemisection case, right? Because opposite side is not much of affected. Now tell me, biceps is lost, which is very typical. What was the root value of biceps? C5 C6. So I can think that probably this is a lesion which is involving C5 C6. Let's come to the option and think it is either C5 C6 or C5 C7, C5 C6. C7 C8 is not going to be the option, so option C and D are wrong for me. Let's go above and look at the side. See, if it was flaccid on that side, that ipsilateral involvement will be there. But let's try to get up the things more clear. Let's draw the same diagram. Imagine that I am having a hemisection at the level of C5 C6, right, and in between the level C5 C6. What would happen to above the level, below the level, and the same level? The same thing we are going to draw here, right? Above the level everything will be normal, we cannot see anything related to that, and it's not of importance to us. At the level C5 C6, what would you get? Ipsilateral element, right? And we are seeing that we are having element on the right side, so definitely this has to be the ipsilateral, means it has to be right side. So till now I know my option which is correct is option B, that is C5 C6 hemisection on right side. But now let's try to get that whether all our combinations of Brown-Séquard syndrome are getting fulfilled or not, right? Pain and temperature, upper limb में lost over the lateral forearm and hand. Tell me, upper lateral forearm and hand, what is that level? C5, right? Lower limb is normal, absolutely fine. On the right there is ipsilateral spinothalamic tract involvement, again C5 से आ रहा है, right? Next, upper limb lost over the medial aspect of arm, forearm and hand. What is this talking about? C8 T1. Yes, because arm will become T1, forearm medial aspect will become C8, hand medial aspect will become C8. So C8 T1, what is that? The level below, the levels far below, right? Levels far below. What will happen? Contralateral loss of STT. We are already seeing this also here, because on the left side there is loss of STT level below the level of lesion, right? Posterior column tract, what is happening? Lost in both upper and lower limbs on the same side. So this is ipsilateral in this case, contralateral is absolutely normal, right? Extensor Babinski positive, that means again this is telling that for lower limb this is UMN. On the left side flexor negative, this is absolutely normal, right? So now what is my diagnosis? To be specific, this is hemisection at C5 C6 on right side. This is how the everything should be correlated. So the take home message for you is learn and understand the orientation of spine with respect to from where the nerves are exiting. Secondly, understand the myotomes, understand the dermatomes, understand the reflexes. Remember the root values by the trick that I have taught you. Understand what is happening with each of the three tracts and try to apply them stepwise manner. Look at the tone and power, understand whether it is upper motor neuron or lower motor neuron for each of the limbs. After that, look at the deep tendon reflexes. You will get the confirmation of UMN or LMN based on that, and based on the based on the sensation pathways, that is the pin temperature, spinothalamic, joint position vibration, that is proprioception vibration, that will be dorsal column. You will get an establishment of the level of the lesion, right? I hope everything is quite understood, quite easy to be cleared up. As much as possible I have tried to make it as easy as possible for all of you. If you still have any doubts in this, just put it down in the comment box or put it down in your telegram. You can message me anytime.